Okay, for our next session, I'm going to ask Victor Pickoff to come up. He's going to moderate, and he's going to introduce his panelists. I think this is another very interesting topic having to do with biomarkers and closing the loop in neuromodulation. So, Victor, do you want to introduce our panelists?
Yes, we have two panelists. We have right next to me is Emmanuel Lerman, who's an MD, but also has a lot of engineering knowledge. Do you have a PhD? No.
I have a master's.
Okay, you have a master's. And yeah, he's from UCSD, but he's also representing his startup InflammaSense. And he will give a quick introduction first. And then Marom Bixon is a professor at City College of New York. There's also a lot of experience in neuromod space, working, evaluating a lot of clinical devices for spinal cord and DBS, and he will also give valuable insight into how this biomarkers can be helpful. But he will present after that. Thanks.
Awesome. Thank you so much, everybody, for having me. Emmanuel Lerman. I'm a neurologist in the anesthesia department at UCSD. I've been in this space since 2012 when I started my research work on vagus nerve stimulation and understanding the effects of vagus nerve stimulation. And over the years, I definitely saw that different things worked in different people. And that was the genesis for my work now. And so the company that we formed is through a BARDA contract through the DRIVE program. And essentially, with that project, we put forward a inflammatory model called lipopolysaccharide. So we inject humans with LPS to see their inflammatory response. You may ask, well, what's the value of that? Well, in our mind, there's a huge value, especially when you're talking about the autonomic nervous system. You can start to understand many different factors, many different components of the autonomic nervous system that essentially change in concert at the exact same time in every single subject. What's different, though, and what's amazing is that between subjects, there are differences in the magnitude of these changes, and we can start to understand who may have more of these changes before they even have this LPS injection. So biotyping or endotyping patients is what we're very interested in. And I'll just talk about some of the things we're doing today in this work, but we're interested in all of these factors. So we do magnetoencephalography, we do EGG, we do electromagnetography with optically pumped magnetometers, and we record this peripheral nerve activity with optically pumped magnetometers and cervical electroneurography with electrodes that we've developed. So what is LPS? It's a component of gram-negative bacteria from E. coli. It acts on toll-like 4 receptors. I think many of you are aware of this pathway that essentially results in immune cells releasing lots of cytokines. Again, what's so interesting is these cytokines go up in crescendo in sequence, right? And so you can see TNF go up, and then IL-1, and then IL-6, and then IL-8, and then interferon gamma. So it's very sequential in its form factor. And we record, again, all these different components here. Let's just... So it's different. Like I said, it's different. The response is different between people. This is a subject that had PTSD, and this is his response at 1 hour time point when everybody has maximal symptoms. Okay. So okay, presentation failed. Next guy is does not have mental health disorder, all right? So his autonomic tone, his autonomic disposition, at the same time point, his cytokines and his neural firing that we recorded was much different than others. So our goal is to identify these factors in humans. We look at multiple different systems. We see when these networks may be in tandem. So is there changes in the gut motility that's syncing up with slow waves in the brain? Are there changes in these neural firing patterns? And we've recently just developed an AI-powered EMR system. So we have a system model that extracts out all electronic healthcare record of every inpatient at UCSD. We're also getting ready to run at the University of Minnesota. And then we've looked at 10 million patients in calipers in the past and seen, okay, when does somebody have inflammation? And the way we look at inflammation is whether or not they have a diagnosis of sepsis. So our goal is to identify patients at high risk for sepsis as their first use case scenario. And Victor asked me to talk about time series and what's important in these different types of measurements. Again, we measure at 16 kilohertz to get action potentials and record these action potentials with our optically pumped magnetometers and our electrodes at the neck. But we're also looking at a lot of other time series. So the heart rate, the respiration, the gut movement, and amongst different pathogens, like I said, with E. coli, at 60 minutes, they have their maximal symptoms, right? And then they go away. Everybody goes away after 6 hours. All their symptoms go away, all their cytokines reduce, and their neural firing goes down. It's a conserved temporal incident, right? Different pathogens can have different periods of time that it takes for them to coordinate immune response, right? So the host response can take different amounts of time for different pathogens that you can actually right now just look at temperature in the hospital and differentiate, say, gram-negative bacteria from gram-positive bacteria. So our goal is to look at these system models to predict pathogen-specific disease severity. We've brought together these different neural sensing mechanisms. This is a picture of the actual prototype that we've developed. This is now in humans at our hospital. We're running a feasibility trial. And in addition to the just running our models at UCSD, we want to run our models at each hospital. So to do that, you can put together everybody's data in what's called open federated learning. And I can take every hospital's data set, put it into a privacy preserving convened consortia, and then essentially run our models all together and generalize them with much higher sensitivity and specificity. So that's the open federated learning. Why is it important? If somebody has sepsis, every 1 hour, they have an increase in mortality rate of up to 7%, right? So as soon as the doctor diagnoses somebody with sepsis, they don't have very much of a runway before they are deceased. So if we can identify that they have this inflammation occurring before that period of time, potentially we can make a big difference. The other thing that we're working on is and this is a closed loop talk, right? So we're very interested in neuromodulation in addition to just sensing, is can we use this model to test your device, right? Can I take a look at your anti-inflammatory effects with our sensing mechanisms? And we're doing that right now. So we have multiple different devices and companies that we're working with. We do focused ultrasound to the spleen. We're going to do focused ultrasound to the cholinergic forebrain. We recorded with MEG in the brain during LPS, and we see cholinergic forebrain nuclei light up. So afferent vagus fibers going to the cholinergic forebrain activate, which you would expect them to during this LPS procedure. The idea is, can we differentiate these endotypes? This is where we are at the moment. Again, we have some non-dilutive funding that's in process, and we're going for a BARDA Plus program. This is our team, and I'll end there. How much time did I go over there? Are there any questions?
You need juice? No, just kind of keep it up. Oh, just share your experiences of great. Yeah. Am I doing it right? Do a swap. No, you got it on screen. It's just you need to swap your screen. There you go.
Let's just do it this one. Let's see this. Shoot. Oh, because it's sending. Okay. Okay, great. I think this will work. Great. So thanks for your attention. I'm going to be talking about personalized therapy, personalized neuromodulation. I think that all neuromodulation is inherently personalized, and how that relates to closed loop stimulation. I won't be talking about any specific products. Just trying to present some general ideas. And what I would like to share with you, really my goal is to say that when we're doing closed loop stimulation, when we're doing any kind of individualized therapy, we really have four kind of markers that we can use. And these are clinical endpoints, biomarkers. I'm going to be defining three kinds of them, triggers and inclusion criteria. And I think that these are concepts that are not always clearly distinguished. And certainly these are some of my own categories to try to distinguish them. But the general idea with individualized therapy is that not everyone gets the same dose, right? People are getting different doses. People might be getting different doses at different times. And so we need a way to figure out what to do. And so a therapy is applied to an individual. There's a certain response, a change in their brain function. We just heard a change in their physiology. Then we look at that response, and then we make a decision of if and how to update dose based on that response. So this is another cartoon that shows the exact same idea. Maybe the response is as desired. So we keep doing exactly what we've been doing so far. Don't change the dose. Maybe the response is not as desired. There's not an adequate response. There's a side effect. And so we make some sort of modification. And in neuromodulation, that's going to be changing where the electrodes are, changing the waveform, or maybe even changing the type of intervention altogether. And so in executing this loop, you can use either biomarkers or you can use either clinical endpoints. I'm going to start to distinguish between what those are, but I want to make it clear that both of those are plugged into this sort of loop of dose optimization. So this is how I'm going to define these terms. This is not like necessarily the medical definition. This is how I'm going to be defining them. So clinical endpoints are the things that you're going to be measuring to ultimately make your claims, to approach the FDA, right, to use in your marketing material. They're the things that you care about in order to justify the efficacy of your intervention. Now, biomarkers are measurements that you make that are not clinical endpoints, but which respond to your stimulation. And I'm going to include biomarkers, and I don't think this is often done. This could be subjective measures, such as a patient report, a physician observation. And I want to emphasize that one person's clinical endpoint is another person's biomarker, right? This is not necessarily an absolute line, but I think it's important to distinguish these things together. And I'm further going to have to distinguish between different types of biomarkers. And so the first type of biomarker I'm going to define, this type 1, is one that basically tracks the clinical endpoint. As the clinical endpoint gets better, it tags along with it, or vice versa. However, I put here the point anticipates, ideally it will change in a more responsive way. So what would that look like, right, in this sort of loop of control system? So I've made it look a little bit more like a control system here. Again, we have a therapy dose applied to the body or brain, and that will change the state of the body or the brain. Now we're going to assess the state of that body or the brain. Again, patient report, an observation, or a measurement. And now this is a biomarker. Right, this is not the clinical endpoint itself. Now, we will assess whether that biomarker is where we want it to be or not. And if it's not, right, we will update the dose accordingly. Now, the clinical endpoints are also improving at the same time, right? So maybe, I don't know, the biomarker is body temperature and the clinical endpoint is treatment of depression somehow, right? But we're using the body temperature in order to cycle through this loop. But the notice is by using body temperature. I know it's a weird example, but by using body temperature to cycle through this loop, we're at the same time pushing the clinical endpoint in the right direction. And this is especially useful if the biomarker responds first, right? If it is more selective, more sensitive to the intervention, because now we're getting ahead of the game, right? Rather than waiting 8 months for the depression symptoms to change or manifest, we have something else, right? An EEG marker that we're tracking earlier. And so that's the biomarker of the first type. Now, there's a biomarker of the second type, which is distinct. The biomarker of the second type marks an acute response to the stimulation that you can typically think of as a measure of the mechanism of action. And I also need to clarify that a biomarker of the second type cannot be a biomarker of the first type or a clinical endpoint. Otherwise, you get into logical inconsistencies. What is an example of that? Some forms, for example, of pain control ask you to increase the intensity until you feel tingling. You can get a TENS device here at the CVS around the corner. You can also get a spinal cord stimulator implanted here at Mount Sinai. In both cases, depending on the type of technology, you will be told to turn up the intensity until just the point where you feel tingling. And why is that? Because it presumed that these technologies work by something called gate control. It's the same thing like when you stub your foot and you rub it. And so the tingling is the mechanism of action. Right now, notice when you turn off the stimulation, right, the tingling goes away. The tingling is not a marker, it's not a biomarker of the first type. The tingling is not a marker of your pain state, right? The tingling is not a marker that you have migraines, right? It is a biomarker of the second type, and that is used to track efficacy. Now, how you'd implement that in the loop is the same thing. Whether you have a biomarker of the first type or the second type, you are cycling through this loop. You're comparing that biomarker against the level that you want it to be. Do you feel tingling? Do you not feel tingling? And then you adjust the points accordingly. But you'll notice there's a difference here. If I stop stimulating, but you stay better, then the biomarker of the first type will also stay better, right? Well, the biomarker of the second type will instantly go away. It will relax because you are not engaging that mechanism anymore. So they have the biomarker of the second type is really an acute marker, whereas the first one is more of a chronic marker. And there is one more. Right? There's a biomarker of the third type, and it's important to distinguish between them. A great illustration of a biomarker of the third type is the finger twitch during TMS. So during transcranial magnetic stimulation for depression, in order to titrate the dose, they put the coil over the motor cortex and they increase the intensity until the finger twitches, right? And that tells them that they have an appropriate level of intensity. Right. Then they do something else. They move the coil somewhere else and they start applying therapy something else. Now, it is a biomarker because it is responding stimulation. However, the finger twitch is not a marker of how depressed you are. It is not a biomarker of the first type. It is also not a biomarker of the therapy of action. Your finger twitching is not how RTMS treats depression, and yet it is still used in the loop in the same way. So you see, we have three types of biomarkers, right? And by the way, the biomarker of the third type cannot be a type of cannot be a second or a first or clinical endpoint. So we're using them in the loop the same way, but you see they have a very different flavor on top of them. And the question then is, just a couple more points I want to make here. If you use them in the loop the same way, does it actually then matter to distinguish them, right? And I think it matters a great deal. It matters a great deal. It matters scientifically. Like, for example, we talked, there's some discussion of using closed loop DBS. So let's say you're monitoring beta oscillations and you're using that to gate your deep brain stimulation, right? It can be rather ambiguous which type of biomarker it is, right? Is the oscillation a marker of the disease? Is the change in oscillation a marker that you are stimulating appropriately? Or is the change of oscillation coincidental? It just happens that when this thing moves, the other things move. So, and it has commercial implications as well. For example, the realization that with spinal cord stimulation, the tingling was a biomarker of the third type and not a biomarker of the second type. That was $1 billion proposition, right? That led to a company, right, that has now subparesthesia treatment. So again, this realization, and it obviously has big clinical implications as well. So if we go back to this general cartoon, where the recognition of which biomarker matters is in this part where you're making dose updates. So when you're looking at the biomarker and then you're deciding what to do with it, I think it's critical to understand that you have three different types. And just to wrap up, I mentioned there's these other things that you could use for individualization. One of them is triggers. A great example of that might be that if you're measuring, you're doing, let's say, auricular vagus nerve stimulation, but you're triggering it based on an inhalation. So they breathe in, you stimulate. They breathe in, you stimulate. The breathing is not affected by the stimulation. So it does not qualify as a biomarker in this sense because it does not respond to stimulation. And yet you are measuring it to control stimulation. So this is shouldn't call it biomarker the fourth type. This is just this trigger. And again, this is sort of how you'd use in the loop. The key point here is that you're stimulating, but that this thing that you're measuring about the body is not responding to stimulation, but it still matters to know it. And then here is just my final slide. The last thing you could do, obviously, is what I'm calling inclusion criteria. I think Dr. Maber said a lot about that as well. This has to do with how you're selecting your subjects, but I want to emphasize that this is going to be for a very specific goal. Like it depends on really what you want to achieve. So thank you.
All right, thank you. You can. So this is
questions for Mom?
Yeah. Well, actually, I think it was kind of just setting up for the discussion. Maron, this is a great setup you created for with biomarker 1 and 2, and maybe I would like to take it to Emmanuel to provide a concrete example. For example, how he would use biomarkers that are tracking the disease progression or therapy versus disease progression is biomarker number 1, and versus the biomarker number 2, which is tracking the therapy application, for acute inflammation, for example.
Yeah.
Can you give examples?
Thank you. Yeah, no, I think that's great. And Maram, I think it's awesome that our presentations look similar. We had the same schematic. I got that from a DARPA presentation, so it's used widely. And you know, when are you measuring is what Victor is saying. Like when are you essentially? And so are we? You know, we're measuring before any stimulation. The only stimulus I gave somebody was an inflammatory load, right? And so I'm trying to measure, you know, baseline to inflammation. Now, going to the next level, and the other thing that I think is critical is that at baseline, there's a lot of information that can be gleaned as opposed to at the level of inflammation. So all those biomarkers can start to separate and segregate amongst individuals different biotypes or endotypes. And we're seeing this very consistently amongst especially patients who have mental health disorder. And it's widely known that inflammation is dysregulated in mental health disorder. There's accumulation of immune cells in the brain, in the periphery. We've done a lot of work showing that this is true also in the CSF and the spinal cord when challenged. So I think that there's, you know, a capability to look at somebody, and you can look at somebody and say, okay, I can't tell if they have any mental health disorder at the moment. Maybe there's some classifiers that look at your facial expression, but you know, the idea is, can we look deeper and start to classify different subjects that may have differences in baseline that may predict, my goal is to predict your likelihood of success in the intervention before you give the intervention, right? So I think, and especially like Helen was talking about, you know, if you look at the changes in the brain that constitute depression, right? The reason why there's people that were refractory to VNS or to DBS is that there's again, the question of when are you in your trajectory of depression? How organized is your frontal lobe in ensuring that it's organized every single negative thought, right? So there's temporal change in people that if you can identify it, you may be able to enrich your population for your trials, as well as enrich your capability to treat somebody.
It's perfect. And then another thing that Maron raised, which I think is a great point, is that biomarker of first type, which is tracking disease, may not be necessary if the patient or physician provided endpoint measures are sufficient. So maybe you can give examples of some diseases where in autonomic space where you think that we don't actually need biomarkers, that endpoint measurements are sufficient, or vice versa, where it's necessary to have biomarkers.
I don't know the answer. I mean, maybe you can, I'm not sure about the answer to that. I mean, I think that there are disease states where obviously, you know, like spinal cord stimulation we were talking about before, we can provide paresthesia-based stimulation. We know that it's causing paresthesia, but we don't know what's happening at the level of the immune cells at the spinal cord level, right? So versus there may be very different effects with high frequency spinal cord stimulation. So there's some disease states where maybe all you need is focused ultrasound that you can, again, like Helen was saying, take care of Parkinson's disease, where there's a certain circuit that you can modify, and that's all that needs to be done, and that there's no neuroplasticity that changes. In spinal cord stimulation, you know, I implant these stimulators all the time, but the problem is what we see is that they work for a while, but then there's neuroplasticity to the stimulation and it doesn't work as well anymore, right? And there's a lot of factors that go into that, but I think
that would be type 2.
Right.
So
yeah.
That would be type 2.
Right. And so, I mean, that's kind of, you know, there's factors in the technology and there's factors in the adaptability. Helen mentioned that there's 2 patients that she was monitoring that she could tell when they're going to get worse, right? So I would like to know that as well. Like, what's the biomarker for not success? Can we monitor that in real time?
Or maybe you can comment. So when we talk about the reduced effectiveness over time due to plasticity or some other effect, would that be yet another type, or would that still be a type 2 type of biomarker when your effect is changing of the therapy?
Right. And so we talked about the issue, and that, again, we keep going back to Dr. Mayberg's thing about not just getting better, but staying better. And we were talking earlier about in the pain space, the challenges of not just getting people to respond, but keeping them responding. So in that case, you have a situation where the same thing that worked before no longer works. So you would presume that in that control system, it is now the physiology that has changed, right? And whereas before the physiology was responding and allowing you to push it in the right direction, now it was being reluctant. And obviously at that point, you're going to be trying to update your dose. And so the notion of the loop and the error correction, remains in place. And, the precise answer to your question, I think will one of the reasons I wanted to present it in this way is I think these discussions get confusing when you're not distinguishing between things like clinical endpoints and different kind of biomarkers. So for example, a very exciting space now in spinal cord stimulation is using feedback and using something called ECAPs, right? So you're stimulating and you're actually measuring the body's response to it. And again, this is one of those things that has led to significant market and hopefully clinical success as well. And again, the question is, that is clearly a biomarker, right? It is a vocal response that cannot possibly be a clinical endpoint, but which type of biomarker is it, right? Are ECAPs a measure of pain state? I don't think so. I don't think people with bigger ECAPs have bigger pain states. Is it a measure of the mechanisms of action? I think certainly some of the companies promoting the space will like to tell you that we're directly measuring the mechanisms of action. Is it a measure of a side effect, right? It's actually something that you're trying to avoid.
I think Salute is pretty clear that it's a measure of dosage of therapy, because it basically shows you how close you are to the surface, which affects the dosage.
It is, but is it a measure of, does ECAP mean it's working, right? Or does ECAP mean is a biomarker of, let's say, the tingling effect? If it's a biomarker of the third kind, then what the ECAP is telling you is that you got your electrodes into the right spot, right? But because it's an ECAP of the third kind, you may not be, for example, able to decrease your intensity to a subparesthesia level, right? And so you did use it. It was a critical part of the equation. But if you realize what kind of biomarker it is, you would treat it differently. And similarly, I think in a very general sense, if you lost efficacy, if you don't understand what the nature of your biomarker, how you're using it, I think it becomes very hard to understand how you can update your strategy.
Do we have any questions from these Zoom? After Zoom. Okay, go ahead.
Is this on? I think this question is probably for Emmanuel or Victor. So I'm curious if you could talk a little bit more about the Open Federated Learning Network. And Victor, I know you're working to create more of a shared data community and philosophy based on more open architecture, while also protecting patient privacy to get the information we need to achieve better outcomes. So can you just touch on that?
Sure. I mean, I can't speak at length about it because the people that are involved are not allowing me to at the moment. So, but there is, definitely a huge empowerment there. And I think that the bottom line is I think it's also a recruitment methodology to recruit academic sites to provide data so that their models work better at their site, right? So the problem is, I don't know if everybody knows about the Epic failure, no pun intended, that occurred 7 months ago or so, where Epic was providing a sepsis prediction classifier, and then others tested that method in a rural hospital and completely failed, right? And so they pulled it from the market. There's no longer a stoplight on your Epic monitor. And so I think that the reason why that is because, the people that they're looking at didn't include those subjects from that hospital. And when you're ramping up to run these models in hospitals, it takes time to even to run the model first before you deploy it. So if we can generalize, if we can get more data sets from more hospitals, and everybody knows it's for the greater good and that the models will work better, and that you can, the other part of it that's super important is you continuously update. So I can send my model to the federated learning convened consortia and then subsequently update it as I'm feeding it new data continuously, like every month or every week if you want. So I think there's, it's a plus for people to become involved. And I think it's a really helpful it's going to improve your model performance essentially. And it's very powerful, I think. Yeah.
What I guess you're referring to is the NIH grant we have from Spark, which is to develop open source and open architecture implantable system. There is actually two grants. One is to USC-based consortium. Another one is for a Case Western-based consortium. Both of these are developing open source, and we're actually talking to each other. So eventually it will be a single system. But unfortunately, at this point, there is no conversation about actually sharing the clinical data. It's only for sharing the technology at this point. But I think the sharing both biomarker data and clinical endpoint data would be very useful for bioelectronic medicine, because we have very heterogeneous populations of subjects in many of these, and figuring out for which of these segments of population where it works or doesn't work, or which side effects we have, would be very useful. Any other questions from the audience?
I have a question, and then I'll see if anyone else does. Marom, I thought your talk was great. This concept of different types of biomarkers, that's new to me. Is this something that's been around, or did you just invent this? Is this, but anyway.
It is, it is a classification that I've come up with, thinking about it the past couple of years, but talking to a lot of other people. Usually the first question I ask them is, what is a biomarker?
Right.
And the conversation stops, and then I know we're onto something. Yeah.
Okay. But anyway, my question has to do with sometimes you see a signal, but you don't know. And you mentioned the what is it? The 50 hertz beta oscillation. All right. Is that is that the mechanism of action? I think there's still some debate. And so when you see a signal, but you're not quite sure which classification of biomarker it would be, and you're a startup or an existing firm developing a new therapy, how do you work with that? How do you deal with a signal that you're not quite sure? Is it type 1? Is it type 2? Is it type 3? Is it type 4? Or is it just totally noise?
Yeah, I appreciate the question. And at one point in one of my slides, I tried to emphasize that in that loop, when you're making dose decisions based on a biomarker, it is a conjecture or hypothesis of what type of biomarker it is. And a biomarker of type 2 today could be a biomarker of type 3 tomorrow. Now, if I'm treating someone and that distinction doesn't really affect and doesn't impact how I then close the loop,
right,
well, then I kind of got away with it, right? I was treating them thinking it was a biomarker of a type 2, and now I realized it's a type 3. So it worked anyways. Ultimately, the proof is in the pudding. There's something else I didn't mention, which is there's another key conjecture or issue in this loop, which is the mechanism of what the dose does itself. So there's actually two things we're guessing. We're guessing what is the mechanism of action of the stimulation, and we're guessing what is the relevance of the biomarker. That is also a conjecture. And as you know, how stimulation works, that is also evolving. And if you're going to wait to launch your company until we figure out how the brain works, it's going to take you a while, right? And so we're living with and of course we don't know how the brain works and what causes these diseases to begin with. But I still think that you can develop a rigorous framework where you're upfront about what your assumptions are. And then in the process of developing your technology, you can either try to hedge your bets against those unknowns, or you can try to address those unknowns, if that makes sense.
Yeah. And that was going to be my follow-up question was, okay, are you worried that this could introduce a level of complexity that might scare off a clinical trial sponsor, right? Because maybe you don't know the answer at the outset. But is it something that might hurt your chances of a successful trial? And as a result, cause a trial sponsor to shy away from that because, like attorneys say, never ask a question you don't know the answer to. And maybe a similar advice would apply to a clinical trial sponsor. I'm just curious if that's a negative of.
Actually, I think Manuel might have answered for this question. Yeah, specifically for we discussed earlier, let's say heart rate measures. There is a lot of them, and we don't know what the value of some of these measures are. Would you still be interested in measuring them in your clinical trial, for example?
Yeah. So there's a panoply of autonomic metrics that you can, measure with ECG or other mechanisms, stroke volume, everything you can think of. They are highly redundant, and we consider them coarse. I'm not sure if it speaks to your question specifically, but I don't necessarily think they provide they provide you information that something's happening, right? And they may provide you information that somebody's at more risk that something may happen. But it doesn't give you granular, recordings from these neurons that are transmitting signals that are specific for certain types of biomarkers being released within the body. So that's the granularity that you may be able to differentiate. But Helen said the same thing with St. Jude, right? She said, they didn't do her brain MRI before the trial and they failed. So the counter argument is that maybe we should be taking a look at these biomarkers, maybe not necessarily a primary outcome of your trial, but there's something that you can retrospectively always take a look at and determine whether or not that was part of the reason why it worked or not.
Yeah, but something different during Helen's trial is the FDA at that time didn't allow you to change your hypothesis, which would have been great for her because she learned later on more by doing this reverse tractography about the neural circuits.
Right. So I guess it made a difference.
But now the FDA has changed, their CDRH has changed their guidance that does allow you to modify your hypothesis in the middle of a trial. So maybe that could be a motivation for a clinical trial sponsor to undertake your new regime there. Any other questions?
So in the context of a lot of these biomarkers, a lot of what we're recording are kind of non-invasive metrics in a lot of these cases, finger twitches or EKG or other varieties. What are your thoughts about, including additional implantable devices that are there for a sole purpose of detecting the biomarker to maybe get it into a higher or a better classification in Marome's schema?
So I'm just going to jump in real quick because Victor and I were just talking about this. They're developing a continuous electrochemical monitoring system on the spleen. And so noradrenergic tone as well as acetylcholinergic tone on the spleen are indicative of whether or not somebody is autonomically hyperdriven, essentially, right? So if they're having continuous noradrenergic release throughout the day, you can start to measure those things and tune. I think it's critical. I think that's where we should be, is tuning our neuromodulation devices to the specific person. And if we can do that continuously, it would change the field, I think. And also with spinal cord stimulation, I mean, the same kinds of molecules that are important can be monitored in real time. And if we can do that, I would love to be able to say to my patient, like, we're going to continuously change the program based upon how you're improving. You don't need X amount of simulation because no longer are you hyperdriven as you were before. So Victor is obviously doing this, and I think it's amazing work.
And just to add that there is actually existence proof that implantable biosensors provide valuable biofeedback. There are a couple of companies. One is called Ability. Another one is MetaCure. Both of them use gastric electrical stimulation, which was triggered based on the events at the stomach. So they were using two different mechanisms. One company, I forgot which of those two, used impedance, and then another one is used pH. One is temperature, one is pH. And in both cases, they were trying to use some kind of algorithm to figure out based on these changes whether patient just had a large meal versus just a drink of water. And if it was a large meal, they would trigger the stimulation because it was obesity and diabetes therapy. So there is already existence proof that both devices are not on the market right now, but the biofeedback loop actually worked. And so there is existence proof that, and an additional advantage of implantable devices is that they're very low power because they're right at the source. So you don't have to distinguish the noise and don't have to do, and of course, another advantage is that it's 100% compliance, essentially patients. You don't have to ask them to wear something.
And it's a great question. Also, as far as obviously there's a cost, right, and a complexity and a risk associated with that modification. So why would you do it? One of the things that sort of started me down this whole road is the recognition is that, as far as I know, there's never been an FDA cleared neuromodulation technology that did not include feedback. Not a single one. Even the TENS unit, you increase the sensation until you increase it until you feel tingling. Cephaly for migraine, they still do it. Increase it until, so all the non-invasives have this little tingly thing built in, right? And DBS, you wouldn't dream of doing it and not titrating it. SES, it'd be insane to implant something in somebody and not do, right, any kind of exploratory programming. So and that's sort of the question I was asking, trying to get at with Dr. Mayberg as well, that it seems like with neuromodulation, you need to do something that you don't need to do in drugs. And so to not have this loop is almost like that's the uncharted territory.
And on the clinical side, I mean, we would, engage, we would embrace, we want these devices that provide us more information so that we can track our patients. And I think that's becoming something that we all look forward to. The issue so we've thought about, we've even put grants together for closed loop devices. And, the feedback we got was the regulatory component is very difficult to get through, and you have to do it sequentially for each device and then subsequently go for a full device. I know that Cala got their closed loop distinction, but when you're talking about biomarkers or sensors and then turning on a stimulation device, it seems like it can be a difficult road to the FDA.
But on the at least for wearable, on the positive side, adding more sensing might actually increase your revenue. As an example, is Cala Health trying to do a multimodal sensing, which improved their reimbursement level, I think, right? So there could be advantages.
Okay. Anyone else with a question? Is there anyone on Zoom? All right.
I guess we will wrap up. Maybe some final thoughts from both speakers, both panelists.
Thanks. As exciting times. I think that there is the autonomic nervous system can be read. I think that there's ways that we can start to, again, identify these biotypes that may improve these therapies. And I hope that, this is already occurring. There's been multiple government agencies that have funded through DITRA, through DARPA, for identifying early onset of sickness or COVID-19. So I think there's a lot of movement in this space at the moment, which is essentially just representative of your nervous system responding to inflammation. But I think understanding who's who and titrating the therapy is where we should be going. And I hope we do.
I don't have anything to add. I love that point about COVID and long COVID. It's something we still live with. And I think there's tremendous opportunity for neuromodulation in that space.
Read your paper. It's good. Yeah.
Thank you so much.